Hello, everyone, and welcome to today's webinar, A Clinical Chemist Perspective of the Benefits and Limitations of Fecal Calprotectin Testing. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. This webinar is educational and thus offers free continuing education credits. Please click on the continuing education window at the bottom of your screen to obtain your credits. I'd like to now welcome our speaker, Dr. Lisa Johnson, Medical Director in Clinical Chemistry at ARUP Laboratories and an Assistant Professor in the Department of Pathology at the University of Utah in Salt Lake City. Lisa, you may now begin your presentation.
Hello, thanks for joining us today. And so today we're going to talk about the pros and cons of fecal calprotectin testing. I have no disclosures. And so the general outline of my talk, I'm going to kind of go in the reverse. We're going to first talk about the post-analytical process. So what are the calprotectin results and how should we use them for the clinical gastroenterologist? And then I'm going to go over the analytical considerations. So what are some of the options for the different platforms available, ELISAs versus immunoassays, and then discuss the two different extraction processes. And then last of all, I'm going to talk about a major consideration, which is the pre-analytical challenges. And that's mostly thinking about using Stool as a sample matrix for this assay. So first, let's just start off with talking about what is calprotectin. So calprotectin is a protein present in leukocytes, and it's a highly sensitive marker of inflammation. And so when the leukocytes are activated, they release the calprotectin into the surrounding area. And calprotectin binds to divalent metal ions, calcium, magnesium, and it's thought to sequester these metal ions from bacteria. And so we know that the leukocytes are activated during this process. So when we're measuring calprotectin in stool, it's a highly sensitive marker for intestinal inflammation. But it is not very specific because it's just a general marker of inflammation. So calprotectin can be elevated for a variety of different disease processes. So it's elevated in IBD, and we're going to talk about that in the next slide. But it also can be elevated for certain cancers or lesions or invasive gastroenteritis. And so it's not very specific for any disease process, but it helps to narrow down for the clinician what might be happening if there's an inflammatory component happening in the intestine. And so for inflammatory bowel disease, IBD, you might guess that calprotectin is elevated because it has an inflammation component, which is correct. So IBD is a non-infectious chronic inflammation of the GI tract. So the immune system is activated for a variety of different reasons, and it's attacking the gut, and so there's inflammation present. And with IBD, the clinicians diagnose these into three different categories. So there's ulcerative colitis, and that affects anywhere from the colon to the rectum. And it's more of the diffuse inflammation of the inner mucosal layer. And then it could also be Crohn's disease. And Crohn's disease affects anywhere in the entire GI tract, from gum to bum, as they like to say. And it's these discontinuous patchy lesions that can affect a variety of the tissue in the intestine. sometimes the clinician won't know exactly which bucket the patient falls in, ulcerative colitis or Crohn's disease. And so they might be diagnosed as indeterminate, and then the clinician will collect more information and maybe diagnose them later with ulcerative colitis or Crohn's disease. And for diagnosis, usually what happens is that the patient gets an endoscopic procedure so that the gastroenterologist can view the inflammation present, and they will collect tissues of the intestine, the biopsies, and bring the biopsies out and send them for anatomical pathologists to view to see if there is these characteristic patterns of inflammation. And that's how it's diagnosed. So inflammatory bowel disease, it's not very prevalent. The prevalence is about 0.4% in North America, so it's pretty low, but it's a pretty serious disorder, and we want to catch it because it's chronic. And so we really need to start treating these patients early and to get these disease processes under control. So another scenario that looks like IBD, at least from the clinical symptoms, that has a much higher prevalence is irritable bowel syndrome. So here, this is IBS. The I stands for something completely different, irritable bowel syndrome. And so this is a functional disorder, meaning that the gut is over or underreactive for a variety of different reasons. It's a clinical diagnosis, so it's diagnosed based on symptoms, and it's highly prevalent. The prevalence is estimated to be about 10 to 15%, maybe even higher in patients seeking a gastroenterologist's advice. And it's diagnosed by the Rome 4 diagnostic criteria, which is recurrent abdominal pain at least 1 day per week in the last 3 months, associated with at least 2 of the following criteria: related to defecation, associated with a stool change in frequency or in appearance. And so a reason that this is kind of problematic is that, patients go to the gastroenterologist, they have abdominal pain, they have diarrhea, and the gastroenterologist has to kind of quickly figure out what is affecting that patient. Should their symptoms be treated, their clinical symptoms, like in the case of IBS, or do they have some kind of inflammatory component that requires further treatment, like inflammatory bowel disease? And so that is one way that fecal calprotectin can be used. And so we have these patients coming into the GI clinic. The gastroenterologist can order fecal calprotectin. If it's low, that means that inflammation is not present, and that maybe a source of their abdominal discomfort is a non-inflammatory cause. And that's more likely in the case of IBS. And so the patient still should get treatment, but their symptoms need to be treated. The gastroenterologist doesn't need to maybe do further diagnoses for that patient. If the fecal calprotectin is borderline, just mildly elevated at 50 to 120 micrograms per gram, then the clinician could think, well, maybe I should retest in 4 to 6 weeks, and maybe just ask the patient what's been going on in the recent history. Have they been taking lots of NSAIDs, because those can cause some bleeding in the intestinal tract, or did they recently have gastroenteritis? And so the recommendation is to follow the patient still closely and maybe retest the calprotectin. If the fecal calprotectin is elevated, that's sort of a strong sign that maybe this patient is having inflammation. Now, we don't know why, and so it's a good move for the gastroenterologist to consider an endoscopic procedure, maybe with biopsies, to further diagnose what that patient is having. So this is a great use for fecal calprotectin as a screening test for IBS versus IBD. Another great use for fecal calprotectin is following patients with IBD. So inflammatory bowel disease is often it's usually a chronic disease in that, the patient has to constantly be seen by a gastroenterologist or followed by their provider just to make sure that everything is doing okay with this patient. They often have relapsed and remitting states of inflammation, and sometimes they might require just different modes of treatment. So here's a study, and you can see it's quite old. It's a good one from 2010, where these authors looked at 140 patients with Crohn's disease and 40 controls, and they looked at the simple endoscopic score for Crohn's disease versus the fecal calprotectin result. So the simple endoscopic score is using a scope and looking at the upper intestine or the lower intestine and measuring how much inflammation is present. And basically how to read this graph, the higher the number, the more inflammation is present and the more severity. And you can see that there's a nice correlation with fecal calprotectin results and the severity of the simple endoscopic score for Crohn's disease. Now this is great because the fecal calprotectin result is much easier to do. The patient can just submit a stool sample, get a result, and the clinician and the patient have some indication of what's going on with the patient. And so it's a great method for following patients with IBD. And if you can compare it to other things that are typically used to follow these patients, so here's kind of some metrics on sensitivity and specificity. So using calprotectin above the cutoff for normal or maybe borderline, you can see that the sensitivity is pretty good for picking up a flare in inflammatory bowel disease. Once again, the specificity isn't so great, but that's because of all the things that we just talked about. People can have inflammation present in their GI tract for a variety of reasons, and it's important to rule out those other reasons. If we compare it to other serum markers that measure inflammation, CRP and the white blood cell count, you can see that they have a much lower sensitivity in detecting those flare-ups in patients with IBD, and then about the same specificity. And if we compare it to a clinical score, the Crohn's Disease Activity Index, we can see that that doesn't compare as well as the lab results. And so the fecal calprotectin result, because it's in close proximity to the intestine, it's actually one of the best tests out there used to follow patients with IBD. It's very helpful to put that information in context with how the patient is feeling and how they're doing with their treatment. Okay, so we talked a little bit about the clinical utility for fecal calprotectin, screening for IBD versus IBS, and following patients with IBD. Next, let's talk about some of the analytical considerations for people interested in bringing fecal calprotectin in-house. So most fecal calprotectin assays are some kind of immunoassay format, and maybe they're an ELISA, and the ELISA exists in this plate format, or maybe they're conjugated to this bead. And so if it's a plate format, usually that plate format is done in batch, so it's done all at once. Sometimes what can be problematic for the batch format is that dilutions might have to repeat it on a second plate, so it might cause a higher turnaround time for high calprotectin results. It's just something to consider. All the steps for a manual ELISA can be accomplished manually, so you don't have to have special equipment. And this is a common method in a specialty lab. And so this is kind of a low entrance point for laboratories thinking about bringing this in-house and maybe wanting to start with an ELISA format first. The other option that people can consider for bringing in calprotectin is the beads. And so the immunoassay is just conjugated to the beads, and the sandwich ELISA happens on the bead. And the thing that's great about beads is that it's random access. You can pop the specimen on the instrument and get the results usually within 20-30 minutes. The dilutions are performed on the instrument, so there's no waiting for the 3-hour ELISA to finish for the dilution. And the only sort of downfall or maybe limitation is that it requires the immunoassay analyzer to perform that assay for that specific vendor. And so those are just some things to investigate if you're interested in bringing fecal calprotectin in-house. And another thing that's important to consider is the method of extraction. So extraction is the process of putting the stool into some buffer and then rigorously shaking it to extract the calprotectin from the stool. And so the gold standard is the manual extraction process. And so what this entails is that usually we do all of our stool extractions within a hood. And so the technologist will stir the stool because we like things well homogenized. And then we will mass out usually about 100 mg of the stool sample and then write down that specific mass on that container and then dilute it with an appropriate amount of buffer. And then that gets rigorously vortexed, and then it often has to undergo a second dilution to be at the appropriate concentration for the assay, and it might need a centrifugation. We're going to contrast that with the device extraction. So the manufacturers have gotten very creative and made many of these extraction devices. And these are pre-filled tubes with buffer, and they have what we like to say in my lab, the magic wand. And the magic wand has these precision grooves, and these precision grooves collect an accurate and precise amount of stool. And you can see I've just shown some of the wands of different extraction devices and just labeled how many mgs of stool they collect. And so it is much lower than the manual weighing process. But the good thing about these devices is that, you poke it into a homogenized stool sample, stick it into the device, vortex it, and then it's often ready to go right into the assay at that appropriate dilution. So if we compare the two processes, so for manual weighing, more stool is used. And because of this, it's often better for highly heterogeneous stool samples. Manual weighing is also better for liquid stool samples because if you can imagine, the liquid stool sample is going to drip off the wand, and that could be problematic. The only issue with the manual weighing is that it takes more time and effort. And if we compare that to the extraction device, so for the extraction device, less stool is used. It's really great for more homogeneous stool samples, and it's also a very efficient process in extracting the stool. So within my lab, we actually sort stool samples by which extraction method they should undergo. And so if you look at the bottom, you can kind of see that I have pictures of gravel shown. And so if there's lots of chunks in the stool or it's highly heterogeneous, then that stool sample is going to be sorted to one for manual weighing because we probably need a larger stool sample to collect the average amount of what's all present to get a more accurate calprotectin result. Whereas if you look more to the right, you can see that the gravel is more finely and it's more homogeneous. And so those kinds of stool samples are more best for the device. And so we sort those into a run for the device, and we extract them in that way. How it usually pans out is we do about 60% of our extractions with the device and about 40% of our extractions for calprotectin through manual weighing. So we actually use both processes because, both are sort of beneficial for certain stool samples. And one thing that labs always wonder is how should we monitor the entire testing process for fecal calprotectin? And so one way that we do this in my lab is that we have a pooled stool QC, which is exactly what it sounds like. It is pooled stool that we try and target a specific range of calprotectin, and it is well homogenized because we want to use this QC sample for both manual weighing and the device. And so we freeze a bunch of aliquots into Eppendorf tubes, and every time the lab sets up a batch of 50 samples, 50 patient samples, they will include a pooled stool QC. And so this is monitoring both our extraction process and our analytical process. And I've shown some data from some of our early studies. These are the Levi-Jennings plots for the manual weighing and the device. And you can see that both perform very well in sort of ensuring that this testing process is tightly controlled. And both are about the same. So as long as the stool is homogeneous, both methods of extraction work really well. It's the more heterogeneous stool samples that we really need to focus on the manual weighing for. And so I would say, perhaps if your lab isn't running a ton of fecal calprotectin samples, you don't want to go to all this effort of making a pooled stool QC. And I totally get it because, it's not, it takes a little bit for our lab to do it as well. And so one method that I could see, smaller labs doing is finding a stool sample that is well digested, that could be just easily homogenized, aliquoting that into Eppendorf tubes, freezing it, and using that as their pooled QC extraction control throughout the runs. And so these are just some suggestions for how laboratories might want to monitor their entire testing process. All right, so we just went through some of the analytical considerations. Let's talk about the pre-analytical considerations. And basically what I'm hinting at here is that stool is just a very challenging matrix, and we already talked about this a little bit in the extraction process. So in my laboratory, I already told you, we sort of sort the stool types based on if they can be done by manual weighing or the extraction device. So here are the different Bristol stool types. So type 1, we kind of think of as hard as rocks. My labs like to shake the container, and if it sounds like rocks, they know it's type 1. It should go to manual weighing. The device can be used from types 2 through 6, or most devices can. And so typically my lab will look at the stool and see if it's well homogenized or if it's highly heterogeneous and sort them to the appropriate extraction method. And then type 7, because the extraction device just doesn't work well with type 7, always goes to the manual weighing. And some issues with heterogeneous samples, we're thinking of undigested food, mucus, and fiber. It just create problems with the extraction device, and we typically use manual weighing. And then my lab also likes to collect these little pill cams. They think it's pretty funny when they see these in the stool sample, and so that's some entertainment for them. But there are other limitations for stool as a matrix for a quantitative result. Mostly there's no normalization. For urine testing, we often normalize to creatinine. The creatinine will give us a hint if it's really dilute or really concentrated, and we can normalize whatever analyte was tested in the urine based on that. There's no marker like that for stool testing. And the water content varies. So stool is mostly water, about 65 to 75% of water in the different Bristol stool types. Another interesting study found that the average within subject coefficient of variation is somewhere between 30 to 40%. So what this means is that if a healthy individual submits a stool sample one day, and then the next day submits another stool sample, on average, that calprotectin result will vary within 30 to 40%. And so this study estimated that a reference change value would be about 100% to 130%. So what that means is that if a patient submits a stool sample and it's 50 micrograms per gram, later on, if they submit a second stool sample, you wouldn't consider the calprotectin result significantly different unless it was at least 100 micrograms per gram. So you need to see a pretty big change in the calprotectin results to see that it's significantly different because of all this variability. So that's kind of wrapping up my talk, just to kind of review the learning objectives. So we talked about the pros and cons of the quantitative measurements in stool. We discussed the extraction process, and I showed you some examples of using a pooled stool QC to monitor the entire testing process. And then we also discussed the best ordering practices or the clinical utility of fecal calprotectin testing that maximizes the benefits for patients. So I'd like to thank DiaSorin for sponsoring this presentation with LabRoots, And last of all, I'd also like to thank my lab for all the wonderful work that they do, and I think they do an excellent job. And with that, I'd like to also thank you for your attention, and I'm happy to answer any questions.
Well, thank you, Lisa, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, can you summarize the challenges and benefits for labs wanting to bring fecal calprotectin in-house?
Sure. I'd say that we've steadily seen a growth in this assay over time. And we also know that patients with inflammatory bowel disease need to be followed pretty closely by the clinicians. And so usually in your local area there'll be like an IBD clinic, and often these patients are sending in samples. And so I think, it benefits the labs to bring this in-house because it's a faster turnaround time to get the results to the clinician. It's certainly of need because, the volumes probably are increasing steadily over time. Some of the challenges, for a clinical chemistry lab, it's probably working with stool. But, the expertise probably exists in your infectious disease laboratories or your microbiology laboratories. And so it could be something that's done in conjunction with those labs to kind of work out the process and find something that suits them.
Great, thank you. Our next question, is there a liquid stool protocol, or do you always have to use the weigh method for Bristol 7 stool samples?
Yes. So with my laboratory, we use the weigh method for the liquid stool samples because we actually just use a transfer pipette and we transfer some of the liquid sample into a container that can be weighed on the analytical balance, and then we do the certain dilutions. Right now, many of the package inserts have a different process where you can pipette out a certain amount with a pipette right into the extraction device. My laboratories did test this, but because we sort of sort the runs specifically based right now on the manual weighing and QSET, we're getting used to our current workflow and we really like it. And so we couldn't figure out which bucket to put these liquid stool samples in if we're doing a separate extraction process from the two that we're already doing. But I would say, labs that have more flexibility in their workflow could probably figure out how to do this with the pipette method, and it likely works.
Thank you. Next question. What are, if any, concerns of false positives or false negatives with this assay?
So with false positives and false negatives, you're thinking more of like what's happening in stool. And so, because it's an immunoassay and it's measuring the protein, I don't know that we've really seen any false positives or false negatives, but it's more thinking what's happening to the patient. This fecal calprotectin could be increased because maybe the patient is receiving cancer treatment and they're having some kind of intestinal inflammation in that sense. Or potentially maybe fecal calprotectin isn't increased because maybe it's a low amount of inflammation higher in the upper or in the small intestine, and maybe it's just too dilute by the time it comes out in stool. And so it's important to think about the clinical indications and why this result might vary a little bit in what would be expected.
Thank you. Next question. The threshold is 50, but do I properly understand that the variation is high and the result can be 100 with another extraction?
So the manufacturers set the threshold for normal. When you repeatedly measure a stool sample, you will see some variation within that stool sample. and that's your analytical variation. So what I was mentioning previously was the reference change value, the variation within a patient. And so I would say that, laboratories have to set the expectations for their analytical variation, and 100 would be quite high because that's quite a bit more stool to get that result. And so I think that that's a little bit elevated, and it would be important to do studies to kind of see what variation you would expect for your analytical side.
Thank you. It looks like we have time for one more question. Do you see FC testing volumes increasing or decreasing in the future?
This testing is actually steadily increasing. The gastroenterologists really like to get this result. They find it very useful to know if the patient has inflammation present in the intestine because this kind of helps them in their diagnostic workup. And so we've seen this steadily increasing. Additionally, patients with inflammatory bowel disease are learning how to read this result and how to kind of follow their disease process. And so that's very helpful for them to make sure that their disease stays under control.
Well, thank you, Lisa. Do you have any final comments for our audience?
Thank you all for attending, and I'm happy to answer any other questions that you have. So thank you.
Great. Well, thank you again, Lisa, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Diasorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.